Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Anurag Jindal, gastroenterologist at Manipal Hospital, Patiala, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hello everybody, I'm Dr. Anurag Jindal. I'm medical gastroenterologist and hepatologist at Manipal Hospital, Patiala, Punjab. Today we'll discuss some important issues about irritable bowel syndrome, IBS.
So doctor, question for you is IBS really a stress disease, or is there more to the story?
IBS is not merely a stress disease, it is a multifactorial disease. There are many factors to the etiology, if we say. One of the most important factors is no doubt the stress. Stress can precipitate the disease, stress can worsen the disease. Stress is a part of etiology of the disease. So it is an important part, and in the treatment of IBS also, we also put medicine for stress as if required. Besides the other etiologies for the IBS other than the stress, there are multiple etiologies like genetics. There is genetic predisposition to the disease. Second is the diet, which is very important. Multiple factors into diet. Besides this, the increased gut motility or the disordered gut motility. Besides, we can say visceral hypersensitivity, increased sensitivity to the normal stimuli. These are the common etiologies. So we can say that IBS is not really a stress disease. So stress is a part of the disease.
What simple screening questions can a consulting physician ask to suspect IBS?
If a patient comes to us, what questions we'll ask that we can suspect that it's IBS? One is altered gut motility. Altered gut motility will be either in the form of increased motility leading on to diarrhea, or decreased motility leading on to constipation, or alternating diarrhea or constipation, or one is increased motility or change in motility. Second question is the bloating. Third is the pain abdomen. Fourth is absence of any alarm symptoms like loss of weight, loss of appetite, any blood in stools, recent change in the bowel habits, or treatment. Besides treatment, the disease earlier was controlled, now it is out of control. Just to exclude the alarm symptoms. If there are no alarm symptoms and there is pain, there is bloating, there is altered bowel habit, these symptoms suggest to the diagnosis of irritable bowel syndrome or IBS.
How important is the patient's history compared to investigations in IBS diagnosis?
Irritable bowel syndrome is mainly a diagnosis of symptoms. History is very important, and the most important is the history, more important than the investigations. Investigations are just in case somebody has alarm symptoms or just to exclude one to other disease. History is more important than investigations. So we always rely on the history, as already discussed the points, and only to exclude few diseases like celiac disease or inflammatory bowel disease, we do investigations. History is more important.
How do you differentiate IBS from lactose intolerance, celiac disease, or functional dyspepsia?
We have to distinguish the irritable bowel syndrome from lactose intolerance. We'll take it one by one. Firstly, the lactose intolerance. The lactose intolerance history contains patient's basically symptoms when he has something in diet which has lactose, like milk, curd, paneer. After these things, patient has symptoms of bloating, altered bowel habit, or pain. Then we suspect there is lactose intolerance. Then we do various tests, most importantly the hydrogen blood test for the lactose intolerance. Secondly, celiac disease. For celiac disease, we do firstly anti-TTG antibody test. It's a blood test, serology test, followed by, if it is positive, upper GI endoscopy and D2 biopsy. Then third comes the functional dyspepsia. Functional dyspepsia, basically, there is no specific test for it. It is a history which suggests the dyspepsia, like upper GI symptoms of heaviness or burning upper abdomen, or the reflux symptoms. And the important thing is here is that functional dyspepsia can coexist with the irritable bowel syndrome, 1/3 of patients. Like that is 1/3 of patients of irritable bowel disease have overlapping functional dyspepsia also. That is, both the things can occur in 1/3 of the patients.
Once IBS is diagnosed, what is your first line approach to management?
Once IBS is diagnosed, the first line of approach of the treatment is the dietary treatment. In dietary treatment, There are many important points. We have to stop initially the FODMAP diet, lactose restricted diet. The amounts of lactose and FODMAP have to decrease or totally stop as per the patient symptoms. First line approach is the dietary management. After dietary management, we say the lifestyle modification in the form of increased physical activity, in the form of cardiac and other exercises. Third comes the stress management, and after that comes the pharmacology. This is how we do the management of the IBS.
How important is patient counseling in IBS management? What key messages do you give?
Counseling is very important because it is a chronic disease, long-standing disease. Patient gets disheartened. Patient tries to stop the treatment. Patient tries to change the doctor. He keeps on jumbling doctor. So ultimately he gets fed up from the treatment. So to avoid getting frustrated and going from one doctor to another, we give a proper counseling to the patient. Like I already told you, the first part of counseling is the positive diagnosis. We tell the patient it is a real disease. You have these symptoms, and this disease is a chronic disease with relapse and remission. So you have to have a patience. We tell the patient that we have to start with the dietary management, then the stress management, lifestyle modification, followed by we add some medicines also. Slowly, we try to decrease the medicines, and the patient remains only on the dietary and the lifestyle modification rather than the pharmacological treatment. So counseling is very important to help the patient continue with the treatment and the lifestyle and dietary modification.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
Yes, regarding the role of diet in IBS, the diet is the most important and first part of management of irritable bowel syndrome. We always recommend the patients to have a low or restricted FODMAP diet. What is this FODMAP diet? Foods which are rich in oligosaccharides like wheat, maize, rice, disaccharides, D like lactose, monosaccharides like fructose in fruit juices and grapes or pumpkins, plums. Then the polyols. Polyols is mannitol and sorbitol, which are artificial sweeteners and many other additives and food additives. There is a 2 to 6 week of extensive phase. We ask the patient to stop all these things. At least 2 weeks. Then after 2 weeks, we look at the symptoms, what symptoms have decreased. Then we start adding one by one of each part of the diet, which is the most important part of our diet, like cereals. Then we look at the symptoms of the patients, whether they get increased after adding the diet. So FODMAP exclusion followed by one by one inclusion in the diet is very important because IBS is a long disease, chronic disease with the remissions and relapses. So we have to definitely modify the diet. We cannot stop the diet. We have to modify the diet. We have to just give the few foods to the patient, which patient has to stop or take in the moderation, that is a low amounts. Initially, we also ask the patient to stop the lactose, especially milk and the paneer. Slowly, we can add upon the other things and ask the patient to just stop the 1 to 2 things in the diet so his quality of life doesn't get stressed. So the role of diet is most important.
How do you handle a patient who doesn't believe IBS is real?
This point is very important because at times IBS patient comes to us because he has already shown to many general practitioners or physicians. Then only patient comes to a gastroenterologist, hepatologist. Many doctors must have told him, or he has read that thing from any book or Google, that IBS is not a disease. But this is the most important point which we have to tell, that IBS is a positive diagnosis. IBS is a disease. It is a disease with a proper etiology, proper symptoms, manifestations, and the treatment. So the most important is we have to tell the patient that it is a real disease, it is a positive diagnosis. Then only we can keep the patient under a treatment follow, because IBS is a disease of relapse and remissions. Patient comes, improves, later on treatment, again the things can worsen. It is a disease of relapse and remissions. So a positive diagnosis that it is a real disease is must. We have to counsel the patient. We have to tell the etiology, multifactorial etiology of the patient. Then accordingly the symptoms and the treatment.
If you could give one takeaway to your fellow physicians about IBS, what would it be?
If we talk about the fellow physicians, patient, because IBS is a very common disease, patient comes to the general practitioner, patient goes to a physician, patient goes to a surgeon, patient goes to a gastroenterologist after he has gone to all these doctors. So it is important to tell some points about the IBS to fellow physicians, like firstly, diagnose it, there are a few criteria for diagnosing it. Take those criteria like pain, abdomen, altered bowel habits. Second, absence of the any alarm symptoms. If you think there is any alarm symptom like loss of weight, loss of appetite, fall in hemoglobin, any blood in stools, black stools, or the patient not getting improved by the treatment of the IBS, then you must send a patient for proper evaluation. Third, exclude already as there was a question, already exclude celiac disease, lactose intolerance, and IBD. Fourth, the dietary management is the cornerstone along with the stress management. Pharmacology management comes always after the dietary management and the stress management. These points are important, and all my fellow physicians, they are doing it. But keep in mind that whenever there is an alarming sign, you must refer patient for proper evaluation like upper endoscopy or colonoscopy.
The most common mistake you see in IBS management?
Yes, the most common mistake I already told you is the telling a patient that it is not a real disease. Sometimes a physician or some doctor can say that it is not a real disease, it is your stress only. Then the patient gets disheartened. He changes the doctor, he keeps on shuffling between the doctors. Tell him it is a positive diagnosis, it is real disease, we'll put you on treatment. This is the most common and the first mistake. Second mistake is straightway going for the pharmacological treatment rather than the dietary management and the lifestyle and the exercises and other things before the pharmacology. So it is important to do all these things before straightway going for the pharmacology. You can start with some pharmacology also, drugs also, but the dietary part, the exercise, stress management part remains the cornerstone. So these are the 2-3 important points which are mistakes are made. Third is ignoring the alarm signs. If you see there is any alarm symptom or sign, definitely refer a patient to gastroenterologist. These are the common things, and if you take care of these things, I don't think there will be any problem in the treatment of the IBS. Thank you.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.